So today we're going to go over an overview of drugs, toxicology, and pharmacology, and really talking about how we classify things. And so forensic scientists, forensic chemists especially, are classifiers. And so what we're trying to do is we're trying to narrow down a substance, either found at a scene or in a suspect or person of interest's home, and try to classify it and see if the classifications match. Now, of course, ideally, if you could classify this down all the way to individualization, that would be ideal. Like, this is a particular type of glass made in a particular type of headlamp on a particular model of car. You see it gets more and more narrow, so that it would be almost impossible for these two things to match if they weren't from the same exact substance. Okay. Now, of course, we know about DNA, and that's the most statistically individual thing we could get to, and you have the DNA profiling, but a lot of times we can't get all the way down to that point. So this idea is classifications. And so we're dealing with drugs today. So we're going to look at how we classify substances related to the drug trade. And so then we need to talk about toxicology too, because some of the effects on the body are ways that we can classify those things. So this is one of my phrases that I want you to remember, like put this in your head, that the toxin is the dose. My kids grew up hearing this all the time. And so then they started using it against us. You know, they dropped something on the floor and like, it's dirty, but the toxin is the dose. It's not very dirty. You know, they would still eat it. We're like, that's gross, cut it out. You know, 6-second rule. And so this idea of drugs that induce a physiological change, they can be ingested and injected, inhaled, and so on, absorbed through the skin. And they're dosed to maximize the activity but minimize the adverse effects. And so you'd have two curves. You have the intended activity that goes up. At a certain dose, you see it start to become active. But then if you go too far, you see the adverse effects curve come up. And you want to be in that window between the activity you want and not in the window of the activity you don't want. And so any substance, if it goes past the activity you want, can get into that adverse effect curve. So that's what we mean by toxin is the dose. A poison is an overdosed drug. Okay. It has a physiological change, that's what makes it a drug, but if it's taken too far, then it becomes a poison. And so this a medicine is a combination of drugs and other formulary components. So we might have an active ingredient in a formulary that is made for ingestion, but maybe we don't want that effect to happen immediately and then go away quickly. So we want a time release or something like that. So maybe we want to coat a basic drug that would be absorbed in the stomach. We want to coat that in something that's not going to fall apart until it gets into the small intestine. So then we get past the rapid release of the stomach and into the small intestine, where it takes a little time for that activity to kick in. And so that's how we would have other formulary components that would protect that substance through the acidic region of the stomach. Or maybe we want rapid fire or like super fast. The BC made a powder. It was like a headache medicine, aspirin powder, and it was real fine, micronized, and you could just dump that into a solution, water or whatever, and then drink it. And it's already dissolved, all ready to go. It goes into the stomach and is absorbed immediately. So it's like a rapid release headache relief. And so that's what we mean by these formulary components, how we form the drug to be absorbed. And then, of course, we have drugs of abuse. And, of course, their definitions change over time. So we've got, we're right in the middle of that right now in this idea of recreational or medical uses of marijuana. So it's kind of an interesting time that you guys are becoming forensic scientists, because there's this huge mess of regulations related to marijuana. And whether it's, allowed for medical use in some states or not allowed at all in other states, or allowed for recreational use in other states, and still Schedule I and forbidden in the federal level versus the state level. This is a very interesting time to kind of be thinking about the law related to some of these drugs. So let's talk about the toxin as a dose. Even water can be deadly at a high enough dose. And that seems strange, because water is such an integral component to our bodies. You wouldn't think that it could ever be toxic, but certain concentrations, specifically sodium, are needed for the functioning of our central nervous system. And so this is a case that happened a few years ago, that a 21-year-old Chico student died, was hazed with water. And so they were told by the university at University of California, Chico, you couldn't haze your students. Obviously, you couldn't haze them with alcohol. They used to have these drinking games that they would force their recruits, their pledges to engage in. And they realized, well, we can't do that anymore, but we could use water. And so they made them drink a lot of water without letting them go to the bathroom. And so this student drank enough water, diluted the sodium in his body, and died. Same thing happened to a 28-year-old mother of 3 trying to get a Wii. And this was when the Wii was brand new. They had a radio program in Chicago, and there was a cute little name, Hold Your Wii for a Wii. And it was, at a remote location, and they had people competing, and they would drink a bottle of water every so many minutes. And she was complaining of severe headaches, and she didn't feel good. And the radio guy said, "What? It's not going to kill you. It's just water." And she died. So they were totally wrong. And so she drank about 2 gallons of water, and that was enough to dilute the sodium in her body. And then her nervous system could not allow her to breathe. The signals weren't getting to her lungs and her heart. I think that was the mode of action. I'm sure that people on the internet will correct that. But it was hyponatremia. And so can you see the word sodium in that? Hypo means low, okay? Natrium is the Latin name for sodium. So that's why it's Na. So hyponatremia is a low amount of sodium in your bloodstream, and that's important for you to be able to transmit signals and make your heart and lungs, and basically, specifically your brainstem communicating, your whole nervous system communicating. But the real important one is your brainstem communicating to your heart and your lungs, beat, 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 and breathe, breathe, breathe. So there's a YouTube link. It should be active on your PDF. You can go and see the news report of her family's successful lawsuit against the radio station owners. Okay. Now, other ways to classify. We could classify our substances based on origin. We talked about classifying them as acid and base, and that's helpful for extraction, liquid extraction, to know if it's absorbed in the stomach or in the intestines, or if we need to do a liquid extraction, changing the pH to drive it into the organic or aqueous layers. But it's not really helpful, as helpful for juries or law enforcement, because a jury member may not know what an acid or a base is and not really care. So classification by origin, that could be helpful. Is it a natural product? Is it a semi-synthetic? A semi-synthetic would be something that's natural that then you modify with a chemical process. And so like heroin is a semi-synthetic. You extract the morphine from the poppy pod, and then you react it and acetylate it, and you can make a heroin with that. And so it's a semi-synthetic. Or a totally synthetic molecule, or a designer drug. We'll talk about what that is. They're sort of catch-all categories that indicate non-traditional origins. Okay. So this is another way. Now, alkaloids, that's an important name. An alkaloid is a plant extract. So something that's been extracted from plants, either like the leaves of plants, the seed pods, like the poppy seed pod. If you scrape the poppy seed, you'll get a latex that comes out, and it can be as high as 10% morphine. So that's pretty high in terms of its content. Okay, and this is a new area. This is Stephanie Basiliere's thesis, and I asked her, can I pull some of your slides? I was on her committee in forensic science where she got her Ph.D. So she came up through the forensic chemistry program, got accepted to our own forensic science master's program, and then while she was in the master's program, we got her Ph.D. approved, so she switched over to get her Ph.D. and her thesis I put on the blackboard, and so you can browse through that. It's fantastic. Okay, and her study was on Kratom alkaloids, so extracts from this plant to produce Kratom. Have y'all seen like signs with the little banners that says Kratom for sale? Yeah, you'll see it in some places. Which is confusing because it's regulated in Texas. But it's an extract from the leaves and the resin of the corth tree. And so the corth tree, the Latin name Metragina speciosa. So metragenine is the active ingredient. They've given that name to the active ingredient from Southeast Asia, but it's being moved on the internet and in retail outlets to get Kratom. And so it comes in various forms, even has been made into pills and so on, and capsules. So here's the chemistry of it. There's 40 compounds present in the leaves, and many of these are psychoactive. So Mg is the abbreviation, and then 7-MgOH are the most potent ones. And so this is metragenine here. Let's see. So this is metragenine, and then this is the OH that it's talking about. So metragenine is about 1/4 that of morphine. So that's not too concerning. But look here, the hydroxymetragenine is 13-fold more potent than morphine. Okay, they measure this in many ways by the binding energy that it has on the mu receptor, and so they can say, okay, it binds 13 times more than the morphine, and so it's going to have a stronger effect, maybe a longer effect. And then other alkaloids, these other compounds, it's pretty difficult to see the differences, but look at this. This is a very small difference. This hydrogen is going away from us. This hydrogen is coming towards us. Okay, so very subtle differences in these molecules, and yet it'll change their binding energy and their potency. And so it's just sort of a gee whiz for you guys to kind of look at. Very subtle changes in some of these molecules can have a huge effect, like putting an OH on that one carbon. Makes the potency go up 46-fold from metragenine. So that's pretty amazing. Now we could also classify by origin other ways. The designer drugs. So cathinones or bath salts. These are kind of they can be sold. They're not sold as drugs. They're sold as, quote, bath salts, things that you would put in the bath or whatever, soften your skin, I don't know. But then people ingest these things and get a narcotic effect or some sort of effect. So these contain synthetic chemicals related to cathinone, a stimulant in the cat plant. Okay. Some of these are cheap substitutes for other stimulants like methamphetamine or cocaine. Then you have synthetic cathinones in MDMA or Molly. They do all kinds of things to ingest them. You can swallow it, snort it, smoke it, inject it. This has always been sort of a troubling concept to me, that you would stick something up your nose or smoke it or inject it. I mean, I guess I can't get my mind into that mindset. Yeah, so even when I'm talking about it, I just feel this emotional dissonance. And so it's still, according to the different sources that I've looked at, and also talking with forensic students doing their projects in forensic science, it's just not clear, a lot of these, how they affect the brain. They can cause paranoia and all kinds of other effects. A lot of these, the effect curve, again, like I was talking about, that you have the first effect curve, maybe the desirable effect, and then shortly after that, it's this window before the adverse effects kick in. We can see, talking about paranoia, we can see that now with cannabinoids that we didn't really see before. So when you were smoking marijuana, you would get the effect, but it would be difficult to smoke it in a potency that would give you some of these adverse effects that now we're seeing with vaping or with edibles. So some of the edibles that have come out have sent people past the euphoric effect, the high that you get, into the paranoia stage, and they'll have psychotic episodes. So that's something that's pretty scary. And so there have been deaths associated with synthetic cathinone. We could classify these by effect. And so the psychological consequences, like analgesics, relieving pain. You have the non-steroidal anti-inflammatory drugs like ibuprofen and the acetaminophen and Tylenol. Then you also have the opiates and their pain-relieving effects. We also have depressants like barbiturates, benzodiazepines, ethanol. Ethanol is probably the most most commonly consumed depressant. And I didn't understand as a kid. I remember in high school health, and they're talking about drugs in high school health. I don't know, did y'all have a health class that y'all had to take in high school? They're talking about the different drugs, and they didn't explain what a depressant was. They just said, well, these are depressants. And I thought, who's going to take a drug to be depressed? That's not the kind of depression they're talking about. They're talking about tamping down the activity of the central nervous system. Okay, and so yeah, you definitely could see the pharmaceutical use of these. If you have anxiety disorder and your central nervous system has got you all locked up, that this could cause you to come off of that anxiety peak and calm you down. Okay, and that would be again the effect that you may want. You go too far, then it depresses you so far that you're not functional. Okay, so this is that window. You want to be in the window of the desired effect and not in the toxin window. Hallucinogens, and this is another thing where again high dose marijuana now, and probably not achieved necessarily through smoking, but achieved in other ways, with vaping or with large doses in terms of edibles. You can get into the hallucination window. And then narcotics. These have analgesic but also depressant capabilities. We see this too, the central nervous system depressant effect. A lot of these opiates will cause constipation. Now, how is that related? That's related from the depression of the central nervous system. What drives your GI tract? Your nervous system. Okay, and if you shut that down, then the little soft muscles don't move things through. So that is a clear effect of the depressant nature of opiates. And then you have stimulants. They stimulate the central nervous, and the most common there is caffeine. Okay, and so then you have people on opiates that are taking large doses of caffeine because they're not moving things through, and so this is sort of stepping on the brake and the gas at the same time. So these are different effects, and this is a way to classify these substances. Let's talk about the pharmacology. So Kratom's effects, but all of these are dose dependent. You know, low doses will produce the stimulant effect, but high doses will produce opiate-like effects. And so you could see in rats, doses over 1,000 milligrams per kilogram, which is very high, they increase the blood pressure and cause severe liver damage, hepatotoxicity, and nephrotoxicity, which is kidney damage. And so it's hitting those two organs really hard. Also, their opiate-like effects for reducing stress has shown potential for addiction and abuse. So, yes, these may enter the scene in terms of their addictive nature and their abuse potential, but then maybe they show some positive effects that could be used by the treatment of other kinds of addictions. And so if they're noticing that metragenine may help relieve the opiate withdrawal symptoms. And so this might be actually an important discovery in terms of the uses of metragenine. The desired effects, of course, would be euphoria, alertness, easing those opiate withdrawal symptoms, pain relief, and sedation. But then the adverse effects are impaired memory, nausea, seizures, hallucinations, liver damage, weight loss, constipation, psychosis. And it sounds like a commercial, when they read all of those different things. Yeah, may cause. And there have been some fatalities in using metragenine or Kratom. And then we could classify them by use. How are they used? So we have so-called date rape drugs, or now the term would be DFSA, or drug-facilitated sexual assault drugs. Alcohol being the most common. They'll list all of these others, ketamine or GHB, but the most common drug-facilitated sexual assault substance would be alcohol. Okay, just because it's readily available and it's legal, you see it everywhere. And so just by supply and demand, it's huge supply. And then supposed club drugs. These are perceived as less dangerous than hard drugs, but again, the toxin is the dose, and so you've got the problems there. And then you've got use for human performance, muscle and fast recovery, like anabolic steroids, testosterone-based substances. These are available in some cases by prescription, but then you can have abuse of prescriptions. You could have unethical doctors. You could have problems with this. And so this might be something that comes into the lab. And, you're not necessarily looking for a drug of abuse for a euphoric high or whatever, but a performance enhancer. And so, that's another way to classify these substances. And then inhalants, opportunistic psychological effects. So this is another thing I can't get my mind around, why someone would sniff paint thinner or gasoline. I'm a physical chemist because I didn't like the smell of chemicals. So I'm in organic and I'm like, oh my gosh, this is awful, And there's some substances, I think it was acetic anhydride, that was what I call Instapute. You go and get it out of the hood and you're carrying it over and you're like, I'm putting it back, and then you see the little sign that says, do not take out of the hood. Come and get your, bring your round bottom to the hood. And I was like, oh, duh, I shouldn't have taken it out of the hood. And so then when I got to physical chemistry, I was like, oh, this is all numbers, and maybe some salt solutions. We did like a freezing point depression. And I was like, that's my lab. So now I'm a physical chemist. Okay. But yeah, to sniff these solvents, I'm thinking, no, sir, do not. And then we could list by schedule. This is the controversial one because our schedules don't match. We have Schedule 1 listed at the federal level and Schedule 1 listed in different states. And so these are legal categories. And so we have drugs of abuse that are subject to regulation, and we have controlled substances. The Controlled Substances Act of 1970 set up these 5 categories called Schedule 1 through 5. And they have different penalties and so on. And so here's some of the sort of the general categories. A Schedule 1 substance has no medical use and has they at that time classified them as potential for addiction, okay? That may still be a valid category, but I think there's been some new conversations related to addiction. We tried to at the time, establish that this substance was physically addictive or this substance was psychologically addictive, as if it was a property of the substance and not a property of the person's personality. Now we're kind of acknowledging that that they both work in concert, right? That the person may have an addictive personality. And what would an addictive personality be? It would be someone who really has very little self-control. So if they could get a drug of abuse, they're going to use it, okay? And if they take that out or make it hard to get, they're going to pick a different one. And if they can't get all of those, they're going to sniff paint. So that's that personality that's driving someone even to the level of sniffing paint thinner. So paint thinner is not necessarily an addictive substance, right? But it's the person's personality that's driving them. And it maybe not just personality, maybe that's too accusatory, maybe it's their circumstances. Maybe their life is such a wreck that they're trying to escape in some way. So it's not as clear as saying this particular substance itself is something inherently addictive, but there could be part of that too. Some of these produce such a euphoric effect that you try it once and you have an 80% chance of trying it again. You try it again, you have an 80% chance of being a lifelong addict. And I've heard that about meth, that it's such a potent effect. Don't ever try it because you're going to get hooked. Okay, and that's what that was a program that the Rotary Club sponsors. Especially the most successful one that I've seen was a Rotary Club in Cleveland here in Texas, trying to prevent young children from getting stuck on methamphetamine because punks were passing these little Jolly Rancher candies that were dosed with meth and passing along to kids to pass out on the bus and getting these kids hooked on meth. Yeah, and so they came up with this Rotary program where all the kids had a little card that they kept in their pocket or in their shoe or whatever, and it had their little answers that said, no, I won't put anything in my body that I don't know what it is, and that kind of thing. And the program was called Don't Meth With Me, which I always thought was a funny name, right? It's kind of like you can't say your S's, right? Don't meth with me. And so, and they had T-shirts and a big, party for the kids, and they rolled it out into the schools and so on. And they were just trying to train the kids to say, no, I'm not going to try anything that you're giving me. That's going to meth with me. So I thought it was a fun and a very good program. And so there's a debate right now about where some of these things should be on Schedule 1. Like here, of course, marijuana is I looked last night, Googled it. Is it still Schedule 1 substance? And it's still at the federal level is still a Schedule 1 substance. You can see here too, medical uses. You have restricted, like these would be, we still can prescribe morphine. In fact, morphine is a really critical drug for treatment of people in hospice. So whenever you're in hospice, that's sort of our best way to treat someone who is imminently dying, right? But we're not going to do anything to prolong their life, but we're also not going to do anything to accelerate their death, right? We're trying to let them go out in peace. I would say the most graceful exit we can give them. And many times these people will get pneumonia. A lot of times, and I have people in my family, so I know this from personal experience, they lose the ability to swallow. So there's for some reason they lose the ability to swallow, and so then saliva mixed with bacteria in the mouth will get into the lungs. They'll get bacterial pneumonia, and so then they just lose the ability to absorb oxygen into their body. And so that's sort of the last stage. And morphine is low doses is a critical drug to relieve them of this feeling of oxygen starvation, of the inability to get a good breath, because that's distressing, and so you're at your last moments, you're essentially drowning, but morphine can relieve that feeling of drowning and keep you at peace without knocking you completely out and just making you not aware of the world. So you can still see your loved ones, you can still somewhat interact, but you're not feeling like you're drowning. And then that's, again, pretty much the last stage of life. And so we don't want to just take these off the table and eliminate them. There's some medicinal uses for some of these compounds. And so that's where it gets tricky. If it's available for use, that means it's available. And then you have unethical doctors or pharmacists getting it into the non-medicinal use areas. Stealing it from veterinarians or something like that. So these kinds of things happen. Then here, some codeine preps and so on, Schedule 3, Schedule 4, sleep aids and Valium, and then over-the-counter drugs, codeine cough syrups and the like. And you see different penalties and fines for abuse and dealing in these things. Now here's the status of marijuana by state. I tried to find what the current, like the latest map was. So this doesn't match the one in your notes because the things have been updated. But here we are. So looks like Texas is CBD and with THC only. There's regulations that have gone. It's been legalized in all of the black states. I didn't pick the colors. That's what's in this DISA document. The green is medical, and the light green, let's see, the light green is decriminalized. So that means the federal law says it's illegal for possession, etc., but the state's not going to prosecute. So that's what they mean by decriminalization. So yes, if you get caught with a bunch of marijuana in your vehicle or so on, they're not going to prosecute. So that's what decriminalization is. It's really kind of a weird thing, it's sort of the prosecutorial discretion. That's something that we have at the state levels. That's something we also have at the federal levels, that the prosecutors can decide if they're going to prosecute a particular crime. Okay, so this is the legal status of Kratom, and this was the latest I could find, which 2000. Oh no, I need to change that. This is 2024, so the heading is wrong. That's the one in your notes on the heading, but this is as of 2024, so it's updated. And we can see that in Texas, it's illegal to distribute, sell, or expose for sale a Kratom product to an individual under 18. So you'll see Kratom but there'll be, again, an age limit on that. Here on the red, Kratom's components are Schedule 1 controlled substances. So the red folks have made it illegal. And the yellow, its components are regulated drugs under state law. In the green, it's illegal to distribute, sell, or expose for sale under 21. So there's 21 in the green states, 18 for the blue states. And then the gray, it's neither regulated nor controlled. So a lot of gray states. So this is a big mishmash of Kratom. And the reason these guys here, this is legislativeanalysis.org, is also sort of giving input. Oh, no, that was the DISA. The DISA document, if you look at it, they were talking about hiring. And so this was a document prepared for human resources people. You know, and they say if you're hiring somebody from one state, you know, they might have a problem with marijuana. If you're hiring them from some other state, it might not be a problem. And so they were trying to inform the hiring people and personnel people and the regulations on marijuana. Also on marijuana here, it says cannabis trends in 2025. It says there's a prospect of the Drug Enforcement Agency rescheduling cannabis from Schedule 1 to Schedule 3. Okay. So, but they're saying until that occurs, the 2025 will be just as rocky as 2024 in terms of the clarity on marijuana. Okay, and this is another Kratom. This is just not the age limits, but just the limitations on possession in Texas, distribution, sale, or manufacturing, and requirements for Kratom product labels. And then still the red and the yellow, those are regulated or controlled as Schedule 1. We could also classify by evidence. So yes, you have the active ingredient, but you also have all of the other things that go with the substance. And so you could have the 5 Ps, and this is in the homework because this is easily testable, right? You have powders, like is it a white powder? Is it a tarry brown substance? So it doesn't necessarily need to be a powder, a tar. This sort of, what is the physical characteristics of it? Okay, is it stinky? Is it amorphous plant-like material that's rotted? Okay, think about trying to keep lettuce, right? After a while, after a week, that lettuce is not great, okay? And if you're trying to sell a plant-like substance, it's not going to keep forever, okay? You want to dry it out, you want to do something that would preserve it, but you could imagine that. And so that would be under the P, like powders and other kinds of properties. And then is it plant-like matter? Is it marijuana, leaves, stems, seeds? Is it a mushroom? I can't imagine a mushroom that's after, weeks old. Moldy goo. And then GVM, I've talked about GPLM. GVM would just be green vegetative matter. So it's some kind of, it doesn't look like a physical tar or powder. It looks like something that came from a plant. So that's the second P. The third P would be pills. And not today, but next lecture, we'll talk about the physician's desk reference. And so this is a block of cards. I mean, I guess it could be a book, but my roommate in graduate school was a pharmacy major. And he had to memorize this. It was flashcards. It was about this big across and about that thick. And it was just one card per pill. And he had to recognize the shape of the pill, the marking on the pill, what the substance was, what it was supposed to treat, and what it had bad interactions with, and what the doses were, the toxin doses. He had certain maximums on the doses. So he just was always working on his cards. So props to him. So this physician's desk reference will tell you this is a Valium, this is an oxycodone, this is a such and such pill. And then precursors. So this is those substances that may be related to the clandestine synthesis of drugs, or they might be, So these are the precursors, things that go into the drugs, and some are listed because of the implications of their possession. Some may be not necessarily listed as a controlled substance, but would definitely, in the totality of circumstances, make the law enforcement nervous. Like, why would you have like 2 cases of Sudafed tablets? 500 packets of Sudafed. Yeah, that's fishy, right? When that is one of the things that goes into making methamphetamine in a clandestine lab. By itself probably wouldn't be enough to get you in trouble, but then if you also had some round bottom flasks in the garage and a 5-gallon tub of toluene or something like that, and a bunch of old batteries, then you've got all the precursors that would be going into methamphetamine. But there might not be any meth in the house or any meth in the garage. But like, why do you have every component needed to make meth? My brother-in-law put those in my garage. Yeah, okay. Yeah. And then paraphernalia. This is that equipment I was talking about. Cookers, pipes, bongs, clips, and straws. There was a case of this young boy had a crack pipe in his, like, hanging from his rearview mirror. This was a student that graduated at my last university, West Texas A&M. He went to work for the state lab, and he was showing me a neat technique that they used with the ATR, the infrared attachment. He said that he just liked it because it was a cool looking piece of glassware. Okay. And they're like, He's like, I never used it. It's never had any drugs in it. He's like, well, let's test that hypothesis. So they put a few drops of methanol in there and switched it around all of the glass and then dripped it onto the ATR and let the methanol evaporate. And so all of that drug residue from the inside of the pipe was concentrated on a 1 millimeter circle, the diamond on the ATR. And they got a beautiful, peak of the crack cocaine that was in that thing, or whatever it was that it was used for. Now, I don't know that they could prove that he was the one that contaminated it, but it definitely proved that his story that it never had anything in it was false. But that little pipe, the little crack pipe, was that paraphernalia. So that would be the way you would classify it. And then these are the most common evidence exhibits according to the book. Okay. And this is not catnip, my story about catnip. So yeah, top 4 at that time were suspected marijuana or plant-like material, methamphetamine, cocaine, and heroin. But now we're seeing all of this other stuff come in, like kratom and bath salts and stuff. But still, these are the most common. And then now we need to include fentanyl on this as well. Fentanyl's being mixed into a lot of these things too, and so that's really problematic. Regional differences exist. Again, this is from the book, and it's it might be dated, but I don't know that Southern California is still a meth haven, but certainly we have a problem with that in the piney woods, and so people can get in remote locations and hide their clandestine drug apparatus. And then we have odd exhibits too. So like PCP, this supposedly, according to the book, greenish solution with an overwhelming smell. I mean, you're going to describe the system or the situation as best you can. And then during Halloween, this was a problem in the 80s when I was a kid. There was some people who I could say, in my worldview, deserve a special place in hell, but they were putting razor blades in apples and giving that out to a kid. Now, who does that? Don't know. But that would be an odd exhibit, not something that's common. So they made us, like our parents would inspect our candy. We'd dump it all out, and they'd go through, and if it was store-bought, like a Mars bar or something like that, and the plastic wasn't messed with, then we could eat it. But if it was anything strange or unusual or didn't look like a commercial candy, name brand, they were like, we're going to take that off. It looks like homemade taffy. It may be great. We're not going to let you eat it. And so nothing homemade. And then we could classify by evidence using the non-drug components, like the cutting agents, things that used to dilute the drug, that would stretch supply or maximize profits. And then that's a cutting agent. The excipient is an inactive ingredient in a commercial preparation, like a time release agent or a binding agent or a buffer. And then adulterants. So this, remember the three components that we had? We had cocaine, procaine, and caffeine. And the caffeine and the cocaine were negatively correlated. And that's what an adulterant is. And so if they want to stretch supply, they can drop the cocaine amount, because that's the expensive piece, and dump in way more caffeine. So they're trying to mask the loss of the stimulant by adding a different stimulant that's cheaper. So that would be an adulterant. So they're making a less potent product, but trying to hide that fact. So caffeine in that case would be an adulterant, and you could classify it by the non-drug components. I mean, caffeine is a drug, but it's not the cocaine. So you would classify that if you had your different seizures, A, B, and C, and there was slightly different color or slightly different bag or whatever, you break those into it, and then you're classifying them. And one way to classify them is by that concentration of the other species. You could also do this by location, okay? Impurities will help you maybe locate where, or patterns in where these things were made or formulated. And here's an example from the text on that, using residual solvent. So you can take these powders and you can put them in a container, and you can put in, one of the ways to do this is put in a solid phase microextraction needle. Now this is a great, let me just show you how that works. You've got a little, it looks like a syringe, and that's just because the syringe, we know how to use a syringe, right? And it's got this little plunger that, down there, and you've got this little metal tube, and when we push the plunger down, the last little bit, I'll draw it wiggly, is a polymer. So we can put that polymer in the GC where it's 250 degrees or a little bit more, and it drives off all the organic molecules. And so it's super clean and super hungry for organic molecules. So we pull that out, we stick it in the headspace above our cocaine packet and warm it up gently, and the solvent, the residual solvent that was in that cocaine powder, will come out and stick on this needle, this polymer needle. And so that we pull it up into its sleeve, quickly go to the GC, punch it in, and then all that solvent comes off that polymer and goes through the GC. And so it's a headspace analysis of the solvent used to produce this drug. So that's a residual contaminant in this solvent, I mean, in this drug formulation, and we could classify our evidence based upon those contaminants. And this is what's being done here. So the extraction solvent or whatever, in this case toluene in this particular data set, was in 59% of cases in the US for this cocaine, and only 7% of cases in Canada. So again, statistically, if you found toluene as a residual solvent, it was probably not formulated in Canada, more likely formulated in Switzerland or the US. And so this is just a way to kind of map out, where did this powder come from? Or where did this substance come from, using residual solvent? Now let's get into the toxicology basics. Star indicates there's homework on this one. Okay, so we want to talk about the pharmacodynamics. That's how the drug interacts with the target and what the drug does and the effect it causes. We've already talked a little bit about that, whether it causes hallucination, stimulation, depresses the CNS. But then let's talk about pharmacokinetics. This is the movement of the drug and its metabolites throughout the body. And I like to call this baby talks, because this is just the tipping our toes into the shallow end of the pool, like 3 or 4 slides, when you can take a whole class on this from Dr. Petrokovics. Okay. So we're talking about ADME. That's the main features of it. So we have to absorb the substance. It will be distributed in the body in some way. It'll be metabolized, and it'll be eliminated. So ADME, those are the main points along the way of a pharmacoactive substance as it goes through the body. So we can think, was it a drug, a medicine, or was it poison ingested? What happened to it? And specifically the metabolites. What happens to that drug as it passes through the body and is eliminated? And so here are the different routes of entry. We can inhale it, ingest it. It could go onto the tongue. I mean, how many people have taken a sublingual formulation? Anybody? Yeah. I have too. It was phentergrin, I think is the name, how you pronounce it, and it's an anti-nausea pill. It's like if you get a stomach bug and you just can't keep anything down, this will calm your stomach and reduce the vomiting or the vomiting reflex. And it's kind of interesting. It makes sense that they would make that a sublingual formulation, because if you can't keep anything in your stomach, it doesn't make sense to give you a pill. Right? You're going to take the pill and you're going to puke it back up. Okay, but if you put it under your tongue and it dissolves and goes right in, if you raise your tongue next time you're looking in the mirror, look at all the blood vessels in the bottom of your tongue. So the saliva releases that substance and it goes right through the tissue on your tongue, goes right into the bloodstream, and then can calm your stomach. So sublingual absorption is one way to do that. Of course, we could have two different types of injection. We can go into, or three, into the vein, that's intravenous or IV injection. Subcutaneous is right below the skin. So that a lot of times insulin is put in subcutaneous. It's just a real shallow injection. And then intramuscular. They show it in the thigh. As a kid, you get it in the buttocks. Adults, most of the time, you get a shoulder. You get your COVID shot or your flu shot, and they put it right into the muscle. And then transdermal absorption. And here's an example here of transdermal absorption. And this is why it's really coming on strong, because this oral application, you take a pill, you want this, see the therapeutic window, you want the time in the therapeutic window to be as long as possible, okay? Because that's when you're getting the therapy of the substance that you're taking. And so in order to increase this area inside the therapeutic window, for an oral application, we have to overshoot that window a little bit. If we just barely hit the top of this, then we're going to lower the therapeutic window. And so we overshoot a little bit with oral application so that the area under this curve inside the therapeutic window is maximized. But we don't want to overshoot so much that we get into the adverse effects trigger point. So we don't want to go too high. And so we still have this sawtooth thing. And you see that on the back of your pill bottles, take every 4 hours or every 6 hours and so on. And that's this time period here. Okay. And we want to do that. We want to space it out so that we don't overshoot and cause liver damage or kidney damage or irritate the stomach. Ibuprofen irritates the stomach and is pretty harsh on the stomach, but it's eliminated through the kidneys. Acetaminophen is metabolized by the liver, so you don't want to go too high on that or you can damage the liver. And this is important for you guys to know in the future, especially with small children, is beware of like cough medicines that have acetaminophen in them, because a lot of parents have damaged the livers of their infants or young children by not realizing that the cough and cold medicine has Tylenol in it. And they were also using Tylenol to reduce fever. So they're giving liquid Tylenol to the child to reduce fever, and they were giving them a children's cough medicine that had Tylenol in it too, and overdosing the Tylenol and hurting their livers. And so that's why I'm not a fan of these combination cough medicines. It's like, give me a cough medicine that treats my cough only, and then if I need an analgesic, a Tylenol, I'll take it separately. But look at the therapeutic window for transdermal. It comes up and sort of maintains this equilibrium with the bloodstream through the skin, and so then it can stay in that therapeutic window longer. And you could compare the areas under these curves. They might be equal, okay, but we don't have the spikes and we don't have the missing sawtooth here underneath the therapeutic window. So that's why transdermal applications can be much better. So here's ADME. We are exposed to, ingested, or some sort of external substance, a xenobiotic, and it's absorbed in the body. Okay. Part of that is the bioavailability, like the rapid release headache powder is really bioavailable. So it goes into the body really quickly, so it's absorbed fast. Then it's distributed. The distribution mechanism in the body is the bloodstream. So even an intramuscular injection, it's stuck in the muscular tissue and it's going to come out slowly into the bloodstream. Then it's distributed over the body. You have storage. This would be fatty storage. So if the drug is fat soluble, it's potential that it gets stored in the fatty tissues. But then as it goes through the liver and the kidneys, those are your filters. The liver transforms the drugs or metabolizes the drugs into something that's more water soluble and can be eliminated by the kidneys. So that's mainly the role of the enzymes in your liver are to metabolize the substance, put an OH on there, put an acid group on there, make it to where it can pass the membranes in the kidneys and be eliminated. So it goes through the liver and then is transformed so that it can be eliminated by the kidneys. And so then that's the last part, E, is elimination. Now, we also defecate, and that would be first pass metabolism. So if something doesn't even go into the bloodstream from the GI tract, then it just goes through the GI tract and comes out. But I'm not as familiar with the back and forth in terms of the GI tract. I know if it never leaves the GI tract, we would call that first pass metabolism. And that's the problem with morphine formulations, is that it has a high first pass metabolism. So that's why morphine is dosed either in the IV or by injection, because if you eat it in a pill form, very little of it gets into the body. And so you have certain drugs, certain active substances that have a high first pass metabolism where it never leaves the GI tract. And so you're not getting the benefit of that substance. It also means you have to give a much higher dose if you want it to have an effect. So that can be a problem too. So so here's the metabolite, speaking of metabolism, of that mitragynine. And here's all the different cytochrome P450s. There's all different kinds, and this is what they do to this drug. And so in Stephanie's work, she tracked down all these metabolites using different enzyme systems, and she could see, well, it's these three enzymes. We'll turn that ester into an acid group. This particular enzyme will put an acid group there, and also turn this ether into a hydroxyl. And there's different pathways. You can do the acid first and come over and get the hydroxyl. You could do the hydroxyl first and come over here and get the acid. You could go straight from the mitragynine through 3A4 and get the hydroxymitragynine. Okay, and so there's an example of this one being moderately potent and that one being 46 times more potent. So the metabolite is way more potent than the parent drug. And so this is one of those interesting things. So these enzymes in the liver and in the bloodstream can cause these transformations in this substance. So this is the dose and elimination curve. And again, this is some equations and some calculations in the homework to do this. So the factors that govern the absorption and distribution, most importantly, are hydrophilicity and lipophilicity. So is it soluble or not? If it's soluble, it's going to go rapidly into the bloodstream, and it's probably going to be more of this straight line up rather than this gradual. So I've drawn this blue line where it's going to shoot up fairly rapidly, and then you'll have this exponential decay. So we'll see this in a little bit, but we're going to use this. Probably the simplest model would be first order kinetics for our metabolism. And so you can do this in Excel. These are the equations for absorption and distribution, and then metabolism and elimination. And we're going to be talking about these biological half-lives. So this is how long it lasts in the body. So we'll have a absorption half-life, So if it's fast absorption, it's going to have a small half-life. So that's sort of the half-life of the substance in your stomach. So it's going to go into the blood quickly. But then the elimination half-life, this could be long or slow, or slow or fast. And that's going to, this ME curve is going to be this red curve. You see the red curve is metabolism and elimination. That's the exponential decay. This is the exponential absorption. And then how long it lives in the body is this green curve. And so this maximum would be that CP, the peak plasma concentration. And that's in this equation back here. This is that CP, plasma concentration. So here's some biological half-lives of some substances that you've dealt with in the chemistry lab. This is from the Occupational Safety and Health book. And you can see some of the early ones like styrene or benzene. Its half-life in the body, benzene is, between 1 hour and 10 hours. It's a log scale on the x-axis, so maybe 7 hours. So if you were to try to monitor, let's say your employees were working with benzene, you would want to monitor them at the end of each shift if they were exposed or not, because by the next day, they've already been through 3 half-lives, and you might not be able to see the benzene in their system. Okay. So every substance has a half-life in the body. Look at cadmium. It's probably the worst, at least it's the worst on this, 10 years or more for its biological half-life. And the diamond means you could only detect it in the blood. So you would need to take a blood sample to detect a cadmium in somebody's body. And it would, again, it takes 10 years or more for half of it to be eliminated from the body. Mercury is in here too. Mercury you could detect in the urine, but it has between a week and a year. So, on the scale of months, you could detect a mercury exposure in the urine samples. This is the curve. When I was talking about the dose effect curve, you have an effect that's desired, and then you have an adverse effect curve. And this is showing the adverse effect curve. And let's pick the death as the adverse effect, right? This would be the dose response curve to produce death. But whatever biological effect you're looking at, the curve would look similar. This is the sort of the general dose response curve that we would see. So you may want to have, like, for the desired effects, you might have a curve that looks like this. Oh gosh, I can't draw. Okay, and this would be desired effect. And so you would want to be in this window, right? And you'd want to be way far away from the death curve. Okay, so, but if you go too far in terms of the dose, then you're going to hit the adverse effects. Now, there's a no effect level. So normal biological variation would cause some people to still respond, but for the most part, people would not respond to these doses. And there'd be nobody dying at that level, but you start to see deaths here. Then there's an effect that's detectable, but it's not adverse, right? And then there's this lowest observable adverse effect level. And that's where you're, I guess, starting to see deaths. This is the LD50. So you'll see that on safety data sheets, the LD50 for this substance, and it's typically in milligrams per kilogram. So we would want to know how many milligrams per kilogram of body mass would be that LD50. And now we want to, I know it's controversial, but we find that out by animal testing because mammalian biology is pretty similar. So we would look at mice, rats, or rabbits. and see what the LD50 is, because it's a dose per kilogram of body mass. And so you have a certain weight of that animal, and you would be able to determine to the best of your abilities what the LD50 is. Now, some people are hypersensitive. Your body has an immune system, and a lot of times that's what's happening with allergies. So short exposure to some toxins may create an allergy or a hypersensitivity. You know, very commonly people are allergic now to peanuts or other tree nuts like pecans. Latex now, that would be a developed environmental hypersensitivity. And sometimes they have to change their jobs. We have a family member who was a medical tech and became allergic to latex. And all of the tubing and the gloves and everything in her environment would cause her to have an asthmatic attack, like she couldn't breathe. And it got so bad, we were at a county fair, and we walk into the exhibit hall, and there were latex balloons in the opposite corner. And she goes, "I gotta go." And she went, and she had to go pretty quickly to the car to get her EpiPen because she was having an attack just from being in the same room where they inflated some latex balloons. So it can be quite dramatic. And so then some of these, though, are long-term, like chronic exposures, no adverse effect level of substances that accumulate, the worst being cadmium and mercury. But we also have substances that may not necessarily do any damage to our bodies, but still collect in our fatty tissues. And one of those is polychlorinated biphenyls. These were used as coolant substances for the transformers on all of our power poles. And they've changed to some other kinds of substances now, but these PCBs, you'll hear about PCB contamination in the plants that manufacture this stuff, and those will collect in the biosphere, and they bioaccumulate. So they get into the plants. Small animals eat the plants, bigger animals eat the smaller animals. They find their way up the food chain, and they end up in us. And so these go from fatty tissue to fatty tissue and bioaccumulate. Now, what about radioactivity as a toxin? Let's just throw that in because we rarely have a chance to talk about radioactivity. Radioactivity is very similar to a sunburn. Okay, so if you think about a sunburn, it's not a toxin that you've taken into your body. It's damage from an environmental situation. So the sun can burn your skin. Now you can have what looks like an immune response to that, but your immune response is not responding to the sun, it's responding to the dead tissues. So the sun has killed skin cells right below your epidermis, and then your body is trying to metabolize the products and take those cells down, destroy those tissues, and redistribute them. So you can have a fever, you can have a high white blood cell count. It looks like you have an infection, but it's a severe sunburn. And that's what radiation sickness is. Okay. And so the radiation is not a chemical poison. There's just some terms in terms of how we calculate the units of dose. But here's the acute biological effects of radiation exposure. So up to 25 rem, that's that no adverse effect level. We don't see any detectable clinical effects. But at 25 to 50, we see a decrease in white blood cell counts. And then when we get to 100, we see an increase in white blood cell counts because they're responding as if there's an insult, like if there's an infection. You would definitely get nausea and fever. And then at LD50 is 500 rem. So whenever we work at a nuclear power plant or a nuclear facility, we wear dose meters. And those dosimeters will be like little film badges. And if we're in a radioactive environment, the radiation will expose that film. And it's going to expose that film, then they read it on a little camera that measures how much that film has been exposed. And they can calculate the dose that you received. It's retroactive, so you've already been damaged. That's kind of a problem, right? But they keep your level really low through administration. So they read these badges once a month or whatever your environment demands, and then they pull you off the job. So they're removed from their duties if their exposure is 0.5 rem per year, so 500 millirem. So the adverse effect level is 25, it's 50 times that, okay? So you would have to have 50 of those exposures before you even saw a white blood cell count decrease. It's way below the LD50. So they say, is it reasonable to work at that level? So we're trying to keep it as low as reasonably achievable. What does reasonably achievable mean? They're saying, well, we've got a function for this business, whether it's generating electrical power or working with medical isotopes. That's our business. Can we fulfill our demands of our business and keep our doses at 0.5 millirem per year? If yes, then do it, right? Why not make it 0.1? Well, maybe you couldn't fulfill the needs of your business at that point, so that's not reasonably achievable, but maybe 0.5 is. And so that's how they're coming up with this 0.5. They're saying, can we still do our business and get our dose as low as possible? So, lastly, let's look at some of the instrumentation that was used on Stephanie's project. This was a time of flight mass spectrometry, and it was a sort of a direct injection called drift. And this is the data that comes off of it. So first you have liquid chromatography separation, and then you have a quadrupole time of flight mass spectrometry, which is high resolution. And these are the chromatographic separations. So this was metragenine, and these were the other species that were in that drug substance and also some of the metabolites. So that's fantastic separation. Like it's what we call baseline separated. So you have the peak here and it goes all the way to the baseline before the next peak starts. Now there's a couple of overlapping peaks. So this one right here has a problem. There's a little signal there from another peak, but we'll see next that we can subtract out those other little peaks that would interfere with this signal by using the mass spec. So it has a high resolution mass spec attached to it. And these are the mass fragments of the metragenine. So the metragenine here, this larger molecule, comes in at 399.2266. So we're getting 4 decimal places in the M over Z signal. So that's fantastic. We can tell the difference between an individual proton or some other kind of sum of all the different isotopes. So we have really high resolution. That's the time of flight part of this mass spec, okay? And then this parent ion will fragment. And you can see the blue lines, how there's 2 ways to go that differ in that carbon atom. So this is the one that contains that carbon atom. So let me connect it here. So if this fragments here, right here, then we still have that carbon atom. And so that's this guy right there. So that's the 238, okay? And if it fragments here, where we don't have that carbon, then it's this fragment here. So that's the 226, okay? And what's the difference between those? 12, 1 carbon, right? So that's really nice. And so then we have the other piece, this green piece over here, that comes in at the 174. So the quantitative ion, this is really great with mass spec. We get the parent ion and its main fragment. And that's this one here and this one here. So when we see those 2 peaks together, we know we have metragenine. And then we have a qualifier ion to say, yeah, this absolutely is unambiguous. We have the other 2 pieces that fragment it off. So that's really fantastic data. Any questions about the mass spec? Okay. Now, part of her project was not just to find the substances and Kratom and so on, but to qualify this as an analytical technique. And so this kind of gets back to the data quality part of our course, that first part of the course. And we have the limit of detection, and she was saying, are we going to get this ion ratios and so on using a signal to noise of 3:1. So our limit of detection was going to be 3:1, 3 times our blank, and our limit of quantitation was 10 times our blank. They test for carryover, and so then you run the analysis, and then you run a blank and see if any of those ions are still on the column. So there'd be carryover from one run to the next. And so you've got to have none of that. So you don't want ions that are stuck on the column for as so long as that they come out in the second run or the third run. So that's the carryover thing. You got precision here. CV plus or minus 20%, and then you've got the bias and interferences, minimal ion contribution from the matrix and internal standards. And so they're testing for all of these things. So if they pass all of these, then that'll be a validated technique, and that's going to help it pass the Daubert test. Is this something that's an acceptable method to be used in forensics? So it's got to have the pedigree of accepted by the community. They're going to publish this work. It's going to be peer reviewed and so on. And then it's going to be a validated technique to where they've looked at the error rates, bias, precision, and those kinds of things. So this is her validation criteria. All right. And then that's pretty much it. We're out of time. So